All right, well, I think in the interest of time, we're going to go ahead and get started. It really gives me tremendous pleasure to welcome everybody back for this segment of the meeting, which is the Fred W. Stewart Award presentation and lecture with Professor Jonathan Epstein. And I have to say, I mentioned earlier that many people from the department are attending the IAP meeting in Jordan. Victor Reuter, who has been a collaborator, former trainee together with Jonathan, is one of our faculty who's in Jordan still. And needless to say, he was very disappointed not to be here, but he did want to be here in spirit. And Samson Fine is going to join me to introduce Dr. Epstein. I think you'll see Dr. Reuter does have a role to play after all. Samson?
Thank you again, Dr. Klimstra. As those who know Victor well know that he has an inimitable way of introducing people and the like. So I'm only going to add my short comments from the perspective of one of nearly 65 former fellows of Dr. Epstein, which is really a monumental event beyond all the other monumental work that Dr. Epstein has done. And on behalf of myself and in the audience, some former colleagues who are now faculty members at MSK, and Dr. Yingbei Chen, another former fellow from our GU Path group, wanted to thank you for helping propel our early careers and continuing to be a friend, collaborator, and inspiration as we go forward. And with that, I would like to cue Dr. Reuter live here in the center.
Good morning and a hearty welcome to our alumni and guests. I am not here physically, but I'm here in spirit and welcome the opportunity to participate in this very important event. The Department of Pathology at Memorial Sloan Kettering Cancer Center honors a pathologist annually who has made outstanding contributions in advancing our knowledge of human cancer by bestowing upon them, him or her, the Fred Waldorf Stewart Award. This year, this recognition falls on Dr. Jonathan Epstein, distinguished alumnus and ex-MSKCC co-fellow with Dr. Mark Rosenblum and myself. He now joins an honor roll of some of the most distinguished pathologists in the world, including Dr. Frank Foote, Dr. Robert Scully, Dr. Leopold Koss, Frank Enzinger, Javier Ariastella, Carl Leonard, Bruce Beckwith, John Carney, Juan Rosai, Robert Kerman, Stanley Hamilton, Richard Kempson, and Robin Young. A distinguished group indeed. The award emphasizes the clinical significance of those contributions, particularly in the diagnosis and patient care. It reflects the traditions and values brought to the Department of Pathology by Dr. Stewart. First as an associate to James Ewing, and then as a chairman of the department for a span that lasted more than 3 decades. Jonathan is from Massachusetts and a fan of the Boston Celtics and other Boston teams that will remain nameless. The fact that he is getting this award a week after our much-loved Yankees were eliminated by the enemy will not be held against him. In fact, all firearms and sharp objects were checked at the door. He got his combined BA and MD at the Boston University. Pathology training was done at Johns Hopkins, followed by a fellowship at Memorial Sloan Kettering, returned to the John in 1984 as co-chief resident and has been on staff there ever since. He is presently director of surgical pathology, professor of pathology, urology, and oncology, as well as holding the Reinhardt Chair of Urologic Pathology. While at Johns Hopkins and with the support of another ex-Memorial Fellow, Dr. Joel Eggleston, he teamed up with Dr. Patrick Walsh, a world-renowned urologist and inventor of the nerve-sparing prostatectomy, to produce a host of landmark publications that continue to inform our understanding of prostate cancer to this day. Dr. Epstein has authored more peer-reviewed journals, articles, books, and chapters that I have read in my entire career. In fact, he has over 900 publications in peer-reviewed journals, and 600 of those or more are directed toward prostate cancer alone. While a fellow at Memorial Sloan Kettering, he already showed his thirst for scientific inquiry, publishing papers on endometrioid carcinoma, now known as ductal carcinoma, and mucinous prostate cancer. It was during this time that we published our first paper together. Jonathan, you might not remember, but it was on herpes-related lymphadenitis, probably not our best work. He is editor of the Biopsy Interpretation series of monographs and author of two of his most influential, Biopsy Interpretation of the Prostate, which is on every pathologist and trainee's desk, and Biopsy Interpretation of the Bladder, together with Dr. Mahul Amin and myself. His contributions have certainly revolutionized our understanding of genitourinary tumors, particularly prostate cancer. His study, published in JAMA in 1994, on the pathologic and clinical characteristics of non-palpable prostate cancer, established the early criteria for active surveillance that is so popular today, and became known worldwide by the urological community as the Epstein criteria. His pathology input was central in establishing the Parton criteria to predict outcome after radical prostatectomy, a paper published by Drs. Walsh, Parton, together with Dr. Epstein. Dr. Epstein was central in redefining how Gleason grading is applied on needle biopsies and prostatectomies. His many publications culminated in the 2005 International Society of Urologic Pathology Consensus Conference on Gleason grading, bringing to the practicing pathologists the criteria to apply Gleason grading in a more clinically relevant manner. Even more significantly, and still seeking to apply criteria for in a more patient-focused manner, he co-authored a publication which created grade groups, which demonstrated differences in biochemical recurrence rates between each group, 1 to 5. Most importantly, it demonstrated significant differences between Gleason 3 plus 4, 7, grade group 2, and Gleason 4 plus 3, 7, grade group 3, as well as between Gleason 4 plus 4, 8, grade group 4, and Gleason 9 and 10, grade group 5. A rarity in pathology publications that rarely uses robust statistical methodology. He recruited other institutions to validate his findings, which led to a landmark publication in European Urology. Over 21,000 cases from the Cleveland Clinic, Memorial Sloan Kettering Cancer Center, University of Pittsburgh Medical Center, Johns Hopkins Hospital, and the Karolinska Institute, validated the findings, but also sent a new standard applied worldwide on how prostate tumors are graded, and now is recommended by multiple bodies, including the World Health Organization, the College of American Pathologists, the International Society of Urological Pathologists, as well as the American Joint Commission on Cancer. As editor and contributor of the 2004 and 2006 World Health Organization Blue Books on the classification of genitourinary tumors, he has helped to shape how we look at GU pathology in a manner that no other pathologist has done in the last 3 decades. Distinguished alumnus indeed. Please join me in welcoming and saluting our 2008 Fred Stewart awardee, my colleague and friend, Jonathan Epstein.
So with that lovely introduction, it gives me great pleasure to present you on behalf of the faculty of Memorial Sloan Kettering Pathology, the Fred W. Stewart Award. Congratulations, John.
Thank you so much.
I'll join him.
You see it?
Yes.
One second.
Absolutely. Thank you. Yeah, so this is a tremendous honor, probably one of my highlights of my career, and very poignant because my year that I was in Memorial was, I think, also one of the highlights, both professionally and personally. In addition to kind of starting my career in geopathology, established many lifelong friends, including Victor, who I was a co-fellow with. And also some of my former fellows, as has been mentioned, are here now at Memorial. So I've maintained my relationship with Memorial, and I consider the Fred Stewart Award the most prestigious award in surgical pathology, and I'm very honored to be the recipient of it. What I'm going to talk to you about today is about the Gleason system and a little bit of history and how it's evolved and how we are practicing currently. So the Gleason system was devised over the 1967 to 77. Donald Gleason was a chair of pathology at the VA. Mellinger was a urologist, and Bayer a statistician. And that's Dr. Gleason on the far left, who's since deceased. Maybe not everyone practices prostate pathology in the area of subspecialization. So very briefly, this is the iconic Gleason schematic diagram. He assigned patterns 1 through 5, 1 being good tumor, 5 being the most aggressive tumor. Recognized that there were heterogeneity where tumors would have more than one pattern. And so what he did, which was very radical at that time and still is radical, is devised a composite score where he said if a tumor was mainly 3, for example, lesser component of pattern 4, you would add them together, 3 plus 4, resulting in a Gleason score of 7. And if a tumor was purely pattern 3, then to keep it within the same spectrum, you'd call it 3 plus 3 equals 6. So grades range from a 1 plus 1 equal 2 to for purely low-grade tumor to a 5 plus 5 equal 10, at least theoretically. Now, what I want to emphasize is that even though we still call it the Gleason system today, it's a very radically different what we practice today as opposed to what Gleason came up with in the 1960s and 70s. Just to show some of the major differences, pattern 2, which was, as I'll discuss shortly, is something we virtually never no one diagnoses that in today's practice, but in Gleason's era, it was one of the most common patterns and actually twice as common as Gleason pattern 4, which is probably one of the most common patterns we diagnose today. Also, just to keep it in perspective, it wasn't just in the 1960s and 60s and 70s, even in the 1990s, so relatively recently. In a study from Hopkins, these were cases that came to Hopkins for surgery where we routinely review all their needle biopsies. And at that time in the 1990s, 22% of prostate needle biopsies on the outside coming into Hopkins, the highest grade was called Gleason score 2 through 4. Again, today we don't do that at all. The other radical difference between Gleason's grading back in Gleason's era and what we do today is the issue of cribriform pattern 3 prior to 2005. This is a study that we did looking at do adenocarcinomas of the prostate with a Gleason score of less than or equal to 6 at radical prostatectomy have the potential to metastasize to lymph node. It was a multi-institutional study, Hopkins, UCSF, Henry Ford, and Baylor. And this is a photograph from that study of cases that were coded and diagnosed as a pure 3 plus 3 equals 6 at these institutions, which are top urological pathology institutions. And these are images from the cases from the 1990s that were called Gleason score 6 at radical with metastases to lymph nodes. Obviously, people who practice geopathology today, looking at these images, these are straightforward, Gleason pattern 4 cancers, aggressive cancers, some of them even 4 plus 4 equal 8. So what was called cribriform pattern 3 prior to 2005, very different than how we practice today. So what changed between the 1990s, the 60s, 70s, 80s, and 90s into current practice? Well, the first thing was in 2000, I wrote an editorial in the American Journal of Surgical Pathology saying we shouldn't be making these low-grade cancer diagnoses on needle biopsy. First, poor reproducibility amongst experts for low-grade tumors. Second of all, if you look at the correlation in studies that we had done between cases that were called Gleason score 2 through 4 at other institutions, and then we looked at the radical prostatectomies at Hopkins on those same cases, up to 50% of those prostatectomies had extraprostatic extension. So to call something a Gleason score 2 through 4 would misguide clinicians and patients into believing that they had an indolent tumor. The next big change in terms of how we recorded and looked at Gleason was the 2005 consensus conference, International Society of Urological Pathology, that I chaired. And on the left is the, again, schematic diagram from Gleason from the 1960s and 70s. And on the right is the schematic diagram that followed the 2005 consensus conference. As I'll show you, there's one major change that we'll get to that has now been modified since this 2005 conference. But if you look here, just patterns 1 and 2, really there was no change between the Gleason and the 2005. The big difference was in 2005 consensus conference, it was thought that if you were going to call cribriform Gleason pattern 3, you were going to restrict it to a very well-defined, unusual cohort of small, well-circumscribed cribriform glands with uniform, round, evenly distributed lumina. And this is an example of something that the consensus conference said, could be potentially cribriform Gleason pattern 3. The big difference between the old diagram and the new diagram is that in addition to tightening up criteria for cribriform Gleason pattern 3, it recognized that there were some glands that were poorly formed that should be in Gleason pattern 4, whereas basically these were in Gleason pattern 3 and not really discussed really much by Gleason at all in his original work. The hallmark of Gleason pattern 3 is individual well-formed discrete glands, and basically you want to be able to mentally draw little circles around these glands with nice well-formed lumina to call it Gleason pattern 3. An area that still becomes the vex of pathologists and even in today's practice and has significant implications is what is a poorly formed gland of pattern 4 versus a potentially tangentially sectioned gland of pattern 3. And why that has so much import is because patients with Gleason score 6, most of them are candidates, or many are candidates for active surveillance. Once you have Gleason score 7, even a little bit, most of those patients currently are not. So the question is, when you see a couple glands that are poorly formed, could that just be a tangential section off of a small, well-formed gland of pattern 3, or is this truly poorly formed glands of pattern 4? Not always easy to do. My criteria is I need to see a whole cluster of these poorly formed glands, not intimately admixed with well-formed glands, for me to be reassured that they couldn't be an artifactual tangential sectioning. So in an image such as this, I would still call this a Gleason 3 + 3 = 6. Gleason pattern 4, again, you can see the big difference was whereas in Gleason pattern 4, there were only these irregular cribriform glands. Now we have cribriform glands, we also have fused glands, and we have these poorly formed glands. And this is what I would require to call something poorly formed glands. On the left, we see well-formed glands of pattern 3. By the time you get over to the right, you see a whole cluster of these poorly formed glands that there are just too many to be potentially attributable to a tangential section off of a well-formed gland of pattern 3. Now, one of the things that happened at the 2005 consensus conference, even though it was accepted that you could have these well-formed, small, round, cribriform glands, when we projected images at the conference, basically virtually none of the GU pathologists were uniformly accepting that they could exist. So I did an inter-observer study amongst experts in GU pathology following the 2005 consensus conference, and showed basically we passed on images of what we thought were the best candidates basically for cribriform Gleason pattern 3. And what we found in that study was that even though theoretically there was this cribriform Gleason pattern 3 in the 2005 consensus conference, in practice, basically GU pathologists were not diagnosing it. That even if you gave them the best potential cases of cribriform Gleason pattern 3, they would find some explanation why they thought it was not good enough for pattern 3, and in practice were calling them pattern 4. And I was doing the same thing. Subsequent to this inter-observer reproducibility study, there have been numerous articles showing that cribriform prostate cancer is associated with a worse prognosis than, for example, poorly formed or fused glands. And that brings us up to the second and the latest consensus conference that I also led in 2014. What was the reason what brought upon this conference is the WHO book was coming out. We wanted to make sure we had everything right. There are some countries where literally the WHO book is the Bible. For example, in Japan, if it's not in the WHO book, that's it. They're not going to do it. So we wanted to make sure, given that sometimes the last WHO book was 10 years ago, we wanted to make sure that we were as up-to-date as possible when the WHO book came out. One of the things that we did differently and that I was a very strong proponent of and helped organize in the 2014 consensus conference that we didn't do in 2005 was to include our clinical colleagues. And I think that in retrospect, it was a mistake in the 2005 consensus conference. So in addition to 67 pathology experts in prostate cancer from 21 countries, we included 20 altogether urologists, oncologists, and radiation oncologists, because anything that we do is not in a vacuum. We're practicing pathology and grading in particular to give our clinical colleagues something that they're going to use to treat and prognosticate with their patients. So if we're going to do something, we need their input and we need their buy-in and able to also disseminate that information after the conference. So one of the things that was decided at the 2014 conference, very simply, all cribriform glomeruloid glands are pattern 4. So now on the right is the updated Gleason schematic diagram, where you can see that Gleason pattern 3 is a homogeneous group of well-formed glands. And what this is translated to is that whereas in the past, as I illustrated in our prior studies, patients with a Gleason score 6 had metastatic disease, some of them even died of cancer, now we have a uniform population of Gleason score 6 where these patients don't die of cancer and have an excellent prognosis. Pattern 4, as I mentioned also now, is much more heterogeneous. Any cribriform glands, fused glands, and poorly formed glands. And pattern 5 pretty much remains the same. The only thing I'll mention about pattern 5, which is something that we've written a couple articles on and I still see it in practice today, pathologists in general across the country have a hesitancy of calling Gleason pattern 5, even when I think it's fairly obviously present. And the reason I think is it's basically assigning a patient the worst prognosis possible, and I think just pathologists aren't comfortable giving a patient such a dire pathology in their report. Nonetheless, if these patients are going to have appropriate counseling in terms of treatment or prognosis, I think you have to give them an accurate grade even when it's a bad prognostic feature. Now, I've shown you a bunch of schematic diagrams about Gleason, both the iconic original and the current. I've always thought, that was fine for the 60s and 70s. We all have cameras now associated with our microscope. I think we can do better than a little schematic diagram. So I came up with this photo montage of Gleason patterns 1 through 3, patterns 4 and pattern 5, which I've sent around to various countries and various state pathology societies. And if anyone's interested, they can email me and I can get them a copy as well. So let me now talk a little bit more about grading, some of the specialized areas of grading. So one is variants of prostate cancer. And I used to basically think you had to memorize how to grade each separate variant distinctly, but eventually came to the conclusion that you can apply the same grading rules that you do for usual prostate cancer that you do for these variants. And that's based on the underlying grade pattern. So, for example, individual well-formed glands are pattern 3, cribriform pattern 4, individual cells of necrosis are pattern 5. And this applies to foamy gland cancer, which is usually pattern 3, but can be cribriform 4, even individual cells pattern 5. Pseudohyperplastic cancers, which are cancers that resemble benign glands, large glands, papillary unfolding, branching, but they're still individual well-formed glands, are pattern 3. Mucinous or colloid cancers, mostly cribriform, pattern 4, but you could see well-formed glands floating in mucin, that would be pattern 3. And these clear signet ring cell-like adenocarcinomas, usually pattern 4 and 5, but occasionally well-formed glands can have those vacuoles and would be pattern 3. A cancer that I'll just spend a little bit more attention to because it can be a little bit more confusing is ductal adenocarcinoma, which are characterized by tall pseudostratified columnar epithelium. The classic prostatic ductal adenocarcinomas are cribriform, so that's straightforward. It's pattern 4, just like usual. Papillary prostatic ductal adenocarcinoma is something that's not entirely analogous in terms of usual prostate cancer, which with rare exception doesn't have a papillary component. It's been shown that the papillary ductal adenocarcinomas are aggressive, typically coexist with cribriform, so we just know that those are aggressive and we give them a pattern 4. So historically, ductal cancers have all been considered high-grade aggressive cancers. There is this newer variant, which basically consists of individual well-formed glands, but are lined by pseudostratified columnar epithelium. It's been termed pin-like ductal cancers because they're well-formed glands, and we've shown in several studies prognostically they do well. These are graded as a 3 + 3 = 6. Some people don't like the term pin-like ductal, even though strictly speaking morphologically it's accurate, because they say ductal has historically been considered something that's high grade and will confuse clinicians. So just to be aware, a synonym is pin-like adenocarcinoma of the prostate. And then ductal adenocarcinomas with necrosis, again, entirely analogous to usual prostate cancer. If you see necrosis, it's pattern 5. So small cell carcinoma is the exception. It lacks gland formation. You might think, why don't you call it Gleason pattern 5? The reason we don't do that is small cell cancer has unique morphology analogous to what you see in the lung, albeit it's not as straightforward. There are a lot of these hybrid examples that are kind of in transition between usual prostate cancer and small cell cancer. Immunohistochemically, small cell cancer is very different than usual prostate cancer, and most important, clinically it's different. Different patterns of metastases, and most importantly, different type of treatment. So we don't call it the same as a Gleason pattern 5. All you do is call it small cell carcinoma. If you have variants of prostate cancer admixed with usual cancer, you would grade the variant, you would grade the usual, and then you just put it together all as one grade. Some cancers are treated with radiation therapy and hormone therapy, and when that occurs, you have two different possibilities when you look under the microscope if you see cancer. One, you'll look under the microscope and it looks like usual prostate cancer, even though the patient's been treated with radiation or hormone therapy. And if you didn't know, you would never have known that the patient had received any therapy. And in that setting, you basically say there's cancer without significant treatment effect, and you give it a Gleason grade just like usual prostate cancer. On the other hand, if you see cancer and it shows treatment effect, and the treatment effect for post-radiation and hormone therapy mimics high-grade cancer. For limitations of time in this lecture, I can't show you images, but it looks more like pattern 5 cancer, even though those patients do well, and it indicates that the therapy has actually been effective. In that setting, when you see cancer with treatment effect, you state that, and you do not give it a Gleason score because, again, that would be misleading. Some newer types of therapy that's being used for prostate cancer are cryotherapy, where you basically freeze the cancer, or high-intensity frequency ultrasound, HIFU, where you basically burn the cancer. And following cryo or HIFU, basically what you have is infarction, either of benign tissue or cancer. It's non-selective. So if you have successful therapy following cryo or HIFU, you basically, just like you would with any infarction, you see scarring, hemosiderin deposition, and you might see ghosts of necrotic tumor. But if you see viable tumor, it's going to look just like usual prostate cancer. You give it a grade, it indicates viable active tumor, and typically they can go back and actually retreat those areas to try to destroy that residual tumor. Intraductal carcinoma, you've heard a little bit about today. It's an aggressive pattern that often represents cancerization of pre-existing ducts, but can be a de novo high-grade precursor lesion. Again, a complicated subject in and of itself, an hour-long topic. But for the purpose of grading, the consensus is do not grade intraductal cancer, because some patients have pure intraductal cancer and they are 100% cured when it's all in situ. In terms of doing immunohistochemistry, relative to grade, you'd only do it if the overall highest grade per part in a case would change depending on whether it's intraductal cancer or infiltrating high-grade cancer. So for example, typically when you have intraductal cancer, there's coexisting obvious infiltrating Gleason score 9 or 10 or Gleason score 8 cancer. And in that setting, if you see something that you're not sure is intraductal cancer or not, I wouldn't recommend doing immunohistochemistry for basal cells to clarify that, because it's not going to change what happens to the patient. They have infiltrating high-grade cancer. But if you have a case that, depending on whether it was intraductal cancer or infiltrating cancer, the grade might be a 3+4 or 4+3, which has different treatments, then in those selected minority of cases, you would want to do special stains. In terms of reporting rules for Gleason grading, an area that's been controversial and confusing is the issue of tertiary patterns. At one point, it was actually used even if you had 2 patterns and a minor component of higher grade. That's no longer the case. So in the past, if you had 448 with a little bit of 5, we used to say 448 with tertiary 5. We now recognize that they behave like 4 + 5 = 9, so we just call these now 4 + 5 = 9. 3+3 with a little bit of 4. Again, we used to say 3-3-6 with the tertiary pattern 4. We now call it 3 + 4 = 7. The big difference, and I'll talk about this shortly, is that we clarify that these cases have a minor component of pattern 4 by recording the percent pattern 4. And I'll talk a little bit about how we record percent pattern 4 lately as well. So one of the big things that came out of the 2014 consensus conference was basically a recommendation, and it's actually mandated now in the CAP, to report percent pattern 4 for Gleason score 7, especially for 3 + 4 = 7 on needle biopsy. And the reason for this, and the major advantage for patient care, is recording percent pattern 4 on these 3 + 4 = 7 patients is for the consideration for active surveillance. So as I mentioned earlier, for the appropriate patient, a Gleason score 6 is accepted for most men to undergo active surveillance. However, and this is something urologists are growingly interested in doing, there may be some men, maybe they're older, less life expectancy, maybe they have a lot of comorbidity, again, less life expectancy. They have a small amount of cancer on the biopsy, their MRI doesn't show a large tumor, and there are just some patients who say, I do not want to be treated by surgery or radiation and want to be treated by active surveillance. And so these patients may be a candidate for active surveillance with the 3 + 4 = 7 if percent pattern 4 is limited. But if you just write 3 + 4 = 7, the percent pattern 4 could be 1% or it could almost be 50% bordering on a 4 + 3, which no one would want to treat with active surveillance. Pattern 4 is also not only useful for active surveillance, but can be used for radiation therapy as well. There are different radiation therapy protocols. Samson showed some data on that as well for 3 + 4 and 4 + 3 in terms of giving neoadjuvant hormone therapy. And in a case with a borderline 3 + 4 versus 4 + 3, you could have one pathologist looking at that case, they would call it a 3 + 4. Maybe another pathologist would sit there and say, well, there's a little bit more 4, I'll call it a 4 + 3. But if a clinician, let's say, gets a report that's a 3 + 4 or 4 + 3, that 3 + 4 could have, again, 1% pattern 4, and that 4 + 3 could have 90% pattern 4. And that borderline case wouldn't be evident in a report just saying 3 + 4 or 4 + 3. But now, taking one of these borderline cases, let's say you still think there's more pattern 3 than 4, you would report it as, the way I do it, approaching 50% pattern 4, 3 + 4 = 7. If you thought there was a little bit more 4, you'd call it a 4 + 3 = 7 with 60% pattern 4. But at least the clinicians could recognize the borderline nature of that case, and they could use other factors, PSA, how many cores are positive, imaging, et cetera, to decide whether they treat those patients more aggressively or less. The other thing that I find helpful sometimes is sometimes it's not so straightforward whether there is pattern 4 or not, especially in the issue of poorly formed glands that I alluded to earlier. So when you record less than 5% pattern 4 in a case, and that's your worst grade in a case, what that leads me to do, and what I would recommend also for others, is that when that's your worst 3 + 4 with less than 5% in a case, basically make sure you go back and look at that case or look at that area that you're calling pattern 4 to make sure that it's unequivocal. Because that's sometimes, just based on that pattern 4, is the difference now between treatment and no treatment. So it's almost to the point of cancer versus no cancer, like it used to be in terms of a misdiagnosis of cancer. So in a way, it's, to me, by recording percent pattern 4, provides kind of a red flag to say, make sure that's definitive pattern 4 in those cases with limited pattern 4. Personal preferences in my practice, and Samson mentioned this as well. If I have a very small focus of 3 + 4 or 4 + 3, I don't give a percent pattern 4, and I mentioned that in the report, because just 1 or 2 glands of pattern 4 could radically change that whole percentage. And I think at that point it's becoming such a sampling issue that it's just not valid to give percent pattern 4 in that setting. There's no consensus. It's left optional to pathologists how to record percent pattern 4. The way I do it is in intervals of less than 5%, 10, 20, 30, 40, approaching 50 for 3 + 4 = 7, 60, 70, 80, 90 for 4 + 3 = 7. I wouldn't do 20.3%, 30.2%. Obviously, it's such a sampling issue and subjectivity that to do anything to any greater extent, I think, is just fooling oneself. But I think the importance of it is it tells the clinicians you're on the low end of percent pattern 4, maybe treat these patients potentially in a different way than if they had a greater amount. When you get into this borderline 40 to 60%, again, they're telling them these are borderline 3 + 4, 4 + 3s, they can use other factors. And when you start getting 80, 90% pattern 4, you're basically saying this is probably closer to a 4 + 4, which is, again, could be treated differently. My own personal preference, if I have Gleason score 9 or 10 in any other part, I don't record percent pattern 4 for the other cases, cores with Gleason score 7, because the Gleason score 9 and 10 will end up driving the prognosis and treatment. And then as a general rule, if I'm kind of struggling, for example, is it a 6 versus a 3 + 4, 3 + 4 versus a 4 + 3, I'll back off and assign the lower grade so I don't necessarily end up having the patient overtreated. The other thing I utilize is levels. So if something looks like potentially maybe it's poorly formed glands, I'll look at a level, and if the glands open up, then I'll back off and call it a 3+3. This was a study done in European urology in 2016, looking at radicals in terms of biochemical occurrence, stratified by percent pattern 4. And you can see how much more information you have by recording percent pattern 4. So you can see Gleason score 6 here, 3+4 with 5% pattern 4, 6 to 10% pattern 4, 11 to 20, 30 to 40. Now you're into the 4+3s, 50 to 60, 60 to 80, et cetera. So you have much better stratification in terms of prognosis by recording percent pattern 4. In terms of tertiary pattern 4s, how do we use it now? We now use it the way you would think just in terms of the English language. We use it when you have 3 patterns and a minor component of higher grade. So on a radical prostatectomy, and again, we only use tertiary on radicals. On a radical prostatectomy, if you have very high grade pattern 5, less than 5% of the tumor, and it's the 3rd most common, hence the word tertiary, the way we report it is 3+4 = 7 with a tertiary or minor component of pattern 5. Somewhat controversial, but what I do, and I think most experts do, if pattern 5 is over 5%, even if it's the 3rd most common pattern, we say that's a significant amount of high-grade cancer. We want to get it into the grade, and so we incorporate it as the secondary pattern as a 3+5 = 8. The problem with reporting something as a tertiary pattern, it's often basically dropped off and not factored into treatment. On a needle biopsy, as a departure from the Gleason, I mentioned some of the major differences from the original Gleason. So Gleason is you take the most common and the 2nd most common pattern, you add them together. A major departure, which is based on the consensus conference, that if pattern 5 is the 3rd most common pattern, even if it's a very small percentage, you include it in the Gleason score. So on a needle, it's in a sense the most common, and then if pattern 5 is present, the highest grade, resulting in the Gleason score. And that's thought that any pattern 5 on a needle is extremely worrisome and should be noted in the report. So again, to summarize for tertiary, 3+4 with less than 5% pattern 5, or 4+3 with less than 5% pattern 5, again, only on radicals. If you have a minor component of low grade, so on a radical or needle, if you just have less than 5% low grade, you don't mention it. So for example, if you have a core with 98% pattern 4 and just a few glands of pattern 3, that's a high grade tumor. You ignore those few glands of pattern 3 and you call it a 4+4 = 8. Something that's not controversial in the United States, but actually is very controversial when you start talking to European urologists and even up in Canada, is the issue of how do you grade different cores showing different grades. The consensus is that you assign individual Gleason scores to separate cores as long as the cores are submitted in separate containers, or cores were in the same container yet specified by the urologist as to their location by different colored inks. So for example, if the urologist does 2 cores from the left mid and they just throw it into a jar without any differential ink, and let's say both of those cores had cancer, even though it might be different grades, you would mentally kind of put them together as one long core and give 1 grade. But if that same urologist took those 2 cores and had 1 ink blue and 1 ink green and said they were from different sites, then you would give the grades separately. The issue that's controversial is a global or composite score, meaning do you take every positive core in the entire case, again, pretend it's one giant long core, and at the end of the case saying this is the overall global or average or composite Gleason score for that case. It was left as an optional by the consensus conference. In the United States, and I get cases from all over the United States, virtually no one in the United States gives global or composite scores. But they do this in Europe and in some parts of Canada. The reason why I don't think it's valid to give global scores is because of multifocality in prostate cancer, which is very common. So you could have a 4+4 on one side and a 3+3 on the other, and so your needle cores could be 3+3 and then 4+4. Adding them all together as if it was one giant tumor, you might end up with a score that's 3+4 = 7, minimizing and giving misleading information when in fact your dominant tumor is a high-grade cancer and that's what's driving therapy. So my belief is you assign the individual Gleason scores, you don't give a score at the end, you let the clinicians factor everything in, they have the imaging, and they typically what they do is they'll take the core or the part with the highest grade and use that for treatment and prognosis. But again, they may individualize it depending if they have other information. In terms of reporting grades and radicals, basically each major tumor focus should be graded separately. So if, again, you have two separate tumor nodules, a 4+4 on the left, a tumor on the right, 3+3, again, this 3+3 is not going to make this other 4+4 behave less aggressively. So you give 2 scores. You don't call it a 3+4 = 7. Typically, we only grade the largest tumor foci. You don't have to report small multifocal low-grade cancers. Exception being sometimes you have a small high-grade cancer and you want to make sure that's in the report. What I'd like to end with is the impetus for a new prostate cancer grading system. So this came about in part because there was a movement to rename Gleason score 6 as not cancer. The reason is the word cancer drives over treatment, and the fear of death from cancer likely plays some role. And if you could remove that label of cancer, maybe you could reduce unnecessary treatment of low-grade disease. The problem is, in the United States especially, we've all been taught cancer, horrible, treat it as soon as you can. That's your only chance to live. And so to tell somebody all of a sudden you have cancer, but hey, maybe we can follow you with active surveillance, is an anathema. And there's been very low penetrance of active surveillance in the United States up until recently. So one of the proposed names that got a lot of press, it was in the New York Times, was let's call these low-grade prostate cancers idle tumors, for example, indolent lesion of epithelial origin. And just to show you how this is not insignificant, in our own Hopkins institution where we have over 1,000 men, about 1,500 being followed on active surveillance, 8% of the men opt out of active surveillance, even though they still qualify for active surveillance based on their pathology, their imaging, et cetera, solely due to anxiety associated with basically living with cancer. Now, again, it might sound strange to rename cancer not cancer, but we've actually done that. I'm a general surgical pathologist. I'm not just a geopathologist. You know, in soft tissue, we've renamed well-diff liposarcs. In extremities, we call them an ALT, so patients don't have amputations for these indolent tumors. In geopathology, we've renamed a subset of low-grade papillary urothelial cancers as pun lumps, because, again, these tumors basically, even though they recur, cannot go on and kill somebody. And most recently, in ENT, we've renamed a subset of papillary thyroid cancers as NIFP, non-invasive follicular thyroid neoplasms, even though morphologically, even molecularly, you know, they look like papillary thyroid cancers, just so we prevent overtreatment. And this has been debated in the literature. I've participated in a lot of these arguments. Is Gleason score 6 cancer or not? So obviously, as a pathologist, I'm in favor of retaining Gleason score 6 as cancer. From the morphological standpoint, Gleason score 6 cancers invade nerves. They look like cancer. They can extend out of the prostate, rarely invade seminal vesicles. We've recently done a study documenting this. From the molecular standpoint, I mean, there's also evidence that I'll show briefly that Gleason score 6 is cancer. Here we see a cancer that's Gleason score 6, you know, extending out of the prostate next to the seminal vesicle. Gleason score 6 exists in a molecular continuum with higher Gleason scores. So one of the hallmarks of prostate cancer that's associated with more aggressive behavior is loss of P10. It happens in Gleason score 6. It's not common, but 5% of Gleason score 6 tumors lose P10. It's more common as you increase the grade. ERG rearrangement, which is the most common molecular rearrangement in all of solid tumors, occurs in about 50% of prostate cancers. It doesn't occur in any benign prostatic glandular tissue. In this large meta-analysis of almost 5,000 patients, all these studies, basically ERG rearrangement is just as common in Gleason score 6 as Gleason score 7. And again, you don't see that in benign tissue. This was a very unique case report that was published in Hopkins by Mike Hafner, who's my current GU fellow, going to be joining the staff at Hopkins next year. I'll go into depth a little bit about it just because it's fascinating in terms of the issue is Gleason score 6 cancer. It was a 44-year-old man. He underwent a radical prostatectomy. 5 years after surgery, biochemical recurrence, got treated with a vaccine, hormone treatment, chemotherapy, radiation. Finally, after many recurrences and many treatments, 17 years after radical, patient died, castrate-resistant prostate cancer. And this is his prostate, and there were multiple, because his tumor was so unusual, how long he lived after having advanced prostate cancer, it was sampled, they did like a lot of studies on his original radical. And what they did was they punched out various areas of his radical, calling various P1s through P9s. And the one I'll highlight is red, is P1. And it turns out that P1 looked like pattern 3, pure 3 plus 3 equals 6, whereas all the other patterns were Gleason pattern 4s. And when you looked at the mutations, basically P1, even though it looked like a Gleason score 3 plus 3 surrounded by higher grade cancer, it lost P10, had SPOP mutations, which you've heard about, P53 mutations. When they looked at the lung metastases, it had the exact same mutations. None of the other higher grade cancers had that panel of mutations. And when they looked at distant metastases, they had the same P10, SPOP, and P53, as well as a new mutation, ATRX. So the thought was that this pattern 3, surrounded by higher grade cancers, basically was a clone that ended up metastasizing to the lung and acquiring additional mutations as it went to liver, other areas in the lung and lymph nodes, not the higher grade cancer. So the implication is, Gleason score 6 may look like Gleason score 6, but maybe, it sometimes can be responsible for metastases and death. We've shown that if you have a pure Gleason score 6 at radical, that was a study I talked about earlier, they're incapable of metastases, but maybe a Gleason pattern 3 in proximity to high-grade cancer, and that could be that's all that's sampled on biopsy, could have biological properties different than a pure Gleason pattern 3. How rare is this case, or is it representative, isn't clear, but what I'll do is just briefly digress and share with you a study that from the European Urology, from the group in Michigan that's in press, where they looked at this issue of pattern 3 by itself versus pattern 3A admixed with pattern 4. And these are some of the more commonly derived or commonly used molecular tests that are out there commercially, Polaris, Oncotype DX, Genome DX. They came up with not using their exact test, but using the same basically molecular profile for these tests in Michigan to look at that. And what they found was that there was no difference in a Gleason score 6, basically from higher grade cancer, whether it was admixed with the higher grade or it was separate. So arguing that that maybe this Hafner case that I reported is an exception rather than the rule, also throwing into doubt whether these commercial gene expression assays performed on low-grade cancer can provide meaningful information on the presence of coexisting unsampled aggressive disease, which is what they're being touted of by the companies. Getting back to his Gleason score 6 cancer, one of the other reasons why I think we still should retain Gleason score 6, calling it a cancer, is the whole sampling issue. So up to 25% of the time when you have a Gleason score 6 on biopsy, there's higher grade tumor in the radical. If on biopsy we came up with some euphemism to not call these cancers, a significant number of men with Gleason score 6 might not be followed as closely and potentially progress to incurable cancer. So if you tell this patient, you have an idle tumor, not a cancer, yet we want you to come back every 2 years to have this horribly painful prostate biopsy, there are some patients who are going to say, I don't have a cancer, I'm just not going to go through this, which I think would be a significant error. In contrast with bladder or thyroid, we have the whole lesion that's taken out. In those cases, when we call it a NIFP or we call it a pun lump, it's a different issue than prostate. So I think, to summarize, we should call it cancer. But I think that whole issue and that whole argument to bringing up should we call it cancer has some validity. And I think what needs to be done is to change what patients think when they have a Gleason score 6 cancer. First, urologists should reassure and educate patients. But as pathologists, I thought we should modify how we report prostate cancer to more accurately reflect their behavior. The problem with Gleason 6, so I mentioned earlier, we don't call Gleason score 2 through 4 anymore. For the most part, we don't call Gleason score 5 anymore. So basically, we have a Gleason system that's theoretical, and patients look them up, that goes from 2 to 10. That's what the grading system goes from. But in practice, we start with a 6. So when you think of it, what grading system anywhere else in any organ system starts with a 6? It's just totally counterintuitive. You start with a 1. So what happens is patients are told they have a 6 out of 10. Logically but incorrectly, they think they have a tumor somewhere in the middle of the grading system, and that contributes to their fear of cancer. I talk to 1 or 2 patients a day. They have they find me on the internet, I'm in lay people's books, and they get their cases sent to me. And I'll talk to them when they call me up and discuss their case and even treatment and prognosis. And the first thing I'll tell them when they have a Gleason score 6 as the highest grade is that this is the best tumor you could have. The lowest grade, just forget that it's a 6. A patient that was very poignant in terms of driving home how the scale out of whack. The scale in Gleason actually translates to patients. It was a patient who called me up and was crying. Literally, I think probably the only patient I've ever talked to that was crying. And he was crying because he was diagnosed with a 3 + 4 = 7. As I'll show you, that's good. It's pretty good. I mean, it's like an 88% cure rate. For cancer, that's, it's excellent. But basically, he had a 7, he was thinking, and in the scale from 2 to 10, 7 is closer to a 10. And the reason why he was really crying wasn't just that, but his wife was recently diagnosed with glioblastoma, which, as probably most of you know, 6 months, a year, 2 years, maybe, at the far end, she might live 3 years. He was crying because he thought he had a 7, close to a 10. He wouldn't be around long enough to be able to take care of his wife with his glioblastoma. On one hand, I was able to reassure him, saying, for the next 10, 15 years, he'll probably never even hear from this 3 + 4 = 7. Don't worry about it. It's not going to impact anything relative to his wife. So it is a problem. This is another study that was done by urologist Stacy Loeb. She's here in New York. A qualitative study about grading. They looked at some focus groups with prostate cancer. The majority of patients said, if you had a simple grading system 1 to 5, it would be much more intuitive and clear than a 6 to 10. 88% would prefer to hear that they have a grade 1 or group 1 tumor than a Gleason 6, even if they were told it's the same thing. And even more telling, 80% would feel more comfortable choosing active surveillance if they were told they had a grade 1 or group 1 tumor versus a Gleason 6, even again if you told them they were synonymous. So names do make a difference. As Samson mentioned, one of the major problems with Gleason is 7, even though it's one number, is not homogeneous. You have tumors with more 4 than 3, 4 + 3, that has a much worse prognosis, as I'll show, than 3 + 4. And 8 through 10 are often just lumped together as high-grade tumors. One of the most common risk classifications system that's used for patients for determining therapy is the DeMeco. It lumps 7 altogether indiscriminately, same thing 8 through 10. So if you were to start from scratch and say, okay, forget Gleason, if I'm going to come up with the best grading system, I want to come up with the simplest system that has the least number of grades, each with their own unique prognosis. So we did this study in 2013 from Hopkins, and we proposed basically a 5-grade system based on the current modified grading system, which, as I mentioned, has many departures from the original grading system. Grade group 1 would be equal to what we currently call a Gleason score 6, only individual well-formed glands. Grade group 2, currently 3 + 4, the verbiage described below. Grade group 3, 4 + 3. Grade group 4, Gleason 8, and grade group 5, Gleason 9 through 10. And the hope is maybe 5 years, 10 years from now, things change slowly in medicine. Maybe we won't teach our pathology residents grade group 4 is equal to Gleason 8. We would just say grade group 4 is this, and not go through that paradigm of Gleason. As was mentioned, in order to validate this, Victor mentioned this, I set up this multi-institutional trial. Memorial was included, along with Hopkins and these others. Huge number, over almost 21,000 radicals. And this is basically with these 5 grade groups. So this is grade group 1, Gleason score 6. Some of these patients have positive margins, tumor out of the prostate, but still an excellent prognosis. Grade group 2, 3 + 4, still an excellent prognosis. Drops significantly down to grade group 3. So you can see you want to keep these separate. Grade group 4, 8 through 10, and grade group 5, 9 through 10. If you look at the biochemical risk-free survival at radical, 96% for grade group 1. As I mentioned, 88% for grade group 2, 3 + 4. Again, this is a good tumor to have. Grade group 3, 63%, 5-year biochemical risk-free survival drops to 48%, and then again drops significantly by almost a half to 26% with a grade group 5. We looked at biopsies, or about 16,000 of them, and even with all the inherent problems of biopsies, grade groups still are excellent separation. We looked at radiation, and this was problematic. So I literally called probably 20 different leading radiation centers in the country. Mass General, Miami, there's an ECOG group, there's a Canadian cooperative group. And the problem was I couldn't use none of these groups I could basically enlist to look at grade groups, because they all use the DeMeco classification system in their database. So all the 7s were lumped 3 + 4 and 4 + 3, so we couldn't tease out their data to look at follow-up. And their 8 through 10s were all lumped together. We couldn't tease it out. There were only 2 institutions, and even Hopkins, we couldn't use the data. So there were only 2 institutions that I could find basically that did it the right way. And to Memorial's credit, they were one of them. Mike Zalewski here pioneering that here at Memorial, and the other Cleveland Clinic. So we looked at about 5,000 patients looking at radiation therapy. The curves are shifted up for biochemical recurrence because the definition for recurrence is different, but still the grade groups separated them out with radiation as well. And now there's been many, many studies out there showing the grade groups correlate with biochemical recurrence, distant metastases, and some people questioned we didn't look at death, we didn't have a long enough follow-up. Now there's studies showing it correlates with death also following radiation and radical prostatectomy. So things have changed. So in 2016, when the validation study came out, you can see that basically the ideal way of grade grouping, which is the 5 grades, less than 6, 3 plus 4, 4 plus 3, 8, versus 9 through 10, only about 12% in the literature. We just did a recent study, it's in Press in European Urology. Looking at the literature, only about 12% of studies were using grades the way they should have been. That increased significantly, up to 34.4% in 2017, but still it's only a third. If you look at the most common way that grades were being used, it's still that D'Amico classification, less than 6, lumping 3 plus 4, lumping 8 through 10, 36 and 30%. And if you look at really still 25%, and this hasn't changed, are using grades where you basically lump 3 plus 4 and 4 plus 3, and you lump 8, 9, and 10, or you're lumping a 3 plus 4, which has an 88% cure rate, and a Gleason 10, which has like a 25% cure rate. So we have improved, but obviously we have, I think, room to improve, and I think using these grade groups will do so. So in summary, the grade groups, I think, more accurately reflects the biology of disease in our current system. We have a grade group 1, it's intuitive. 1 out of 5 is much better than a 6 out of 10. Excellent prognosis, no metastases if it's pure. Avoids this whole issue of is there a pattern 1 and 2, and that's why I didn't even talk about patterns 1 and 2, because for the most part they don't exist in my mind. It's all grade group 1. Grade group 2 as opposed to a 7 out of 10, again, it makes sense. 2 out of 5 is good, 7 out of 10 is bad. Very good prognosis. They are rare metastases. Grade group 3 basically forces people to separate out the 3 plus 4s and 4 plus 3s. Grade group 4, again, it forces people to not combine it with 9 through 10. It has twice as good a prognosis than 9 through 10. In grade group 5, it doesn't make a difference if it's a 4 plus 5, 5 plus 4, 5 plus 5. These are all bad actors. So the recommendation, how to use this is on a needle biopsy, you give the Gleason score, since that's what still everyone is still uses and still comfortable with, but you give the grade group as well, put it in perspective. As I mentioned, you give the percent pattern for it, and you give the extent of cancer. On a radical, same thing, and if there's a tertiary component less than 5%, for example, pattern 5, that does not currently affect the grade group. Basically, the grade group is tied in with the main grade. Tertiary pattern 5 is kind of conflicting data. Some studies it bumps it up only a half a grade, some it bumps it up to the next grade. So until there's consistency with that, for now we keep the grade group 2 with the main tumor. And what you do is you assign each part its Gleason score in the grade group. You don't give an overall grade group for the case, just like I mentioned earlier, you don't give an overall Gleason score for the case. Typically, the clinicians will take the highest grade group and the highest Gleason score per part, and typically that's what's being used for treatment and prognosis. As was mentioned, the grade group system has now been accepted by the WHO, the CAP, which basically accredits most of the labs in the country. So it basically means once the CAP is mandated to use the grade groups, pretty much all labs now are doing that, and the AJCC TNM 8th edition. And with that, I'll conclude. Thank you.
Have any questions before we break for lunch? Wonderful thought.
I think that you simplify our work.
I'm a simple person, so hopefully so.
Maybe I missed it, but did you show data comparing 5 plus 3 and 4 plus 4 as the
Yeah, so actually, there is I always put these at the end. No one's asked me that, but I threw these at the end. There are conflicting studies about 3 plus 5 and 5 plus 3, where there should be grade group 4. I think there's now actually a growing number of consensus studies out there that 3 plus 5 acts like an 8. 5+3 for the most part almost never exists. We're actually, it's, in our data it was like 0.1 or 2%. So it's somewhat of a tempest in a teapot. We are looking at actually with Michael Hafner molecular studies for these cases where there are such discrepancies. Do these represent separate clones or are they the same tumor? But it's a relatively rare event.
All right, thank you. One more.
Thanks for a great talk. So it looks like genetic information is very useful. So is there a formal discussion about integrating it to the whole grading system?
Yeah, so the role of molecular in grading and in prognostication in prostate cancer, I would say, is in evolution. The problem is most of the molecular studies, number one, have been driven by companies, so there's obviously some agenda. And most of those studies have been done on radicals and saying that they correlate with prognosis, and then they say we would then apply that to biopsies because it should have the same, basically, prognostication. The holy grail is for active surveillance. So, for example, doing a molecular on a 3+4 = 7 and saying that's a good actor, you can follow that, or do a molecular on a 6 and say even though it looks like a 6, you wouldn't want to do active surveillance. The problem is all those molecular signatures and those companies haven't really done those studies on active surveillance populations and have not followed those patients for a long time. Again, the latest big study from Michigan, which is coming out, I think raises serious concerns whether you can look at a 6 and say that's a bad 6 based on its molecular. It's based on the Michigan series, you would say that can't be done. So at this point, they're not being used that much. What's often being used is almost a reassurance to patients. So if a patient's thinking of active surveillance and they get the molecular and the molecular says this is a good prognostic signature, it just makes the patient feel one more thing to say, yes, I'll stay on active surveillance. But I'm not really sure the role of that, and also with the imaging, how all of that's being factored in is still, I would say, definitely in evolution.
One more question.
Any general tips on recognizing intraductal carcinoma versus high-grade cancer?
Yeah, so intraductal cancer, as I said, is one of the worst prognostic factors in cancer. Even in the setting of advanced metastatic prostate cancer, even then it ends up being prognostic. Having said that, again, most of the time when we see it, it's with high-grade cancer, probably is not critical. PIN versus intraductal cancer, we came up with the criteria, the very well-defined criteria on biopsy where it's critical for PIN versus intraductal cancer. We published those. If it's cribriform, but it's over like 70% epithelium, that's intraductal cancer. If it's a solid nest, that's intraductal cancer. If it's necrosis, it's intraductal cancer, or marked pleomorphism, it's intraductal. As with anything, there are borderline cases. So when I diagnose intraductal cancer, because it's typically associated with high-grade cancer and it's a bad prognostic, I actually say these patients should be treated definitively. So I'm comfortable if I diagnose intraductal cancer only that they go on to radiation or radical. Because it has so much of an import when I make that diagnosis, again, I have very strict criteria. And there are cases that are just borderline, PIN versus intraductal. And in those cases which don't quite fit the criteria, they're worse than PIN, not quite up to intraductal, I'll say it's borderline, recommend a repeat biopsy in those cases.
Jonathan, thank you very much.
Thank you
Great
so
talk.
much.